treat patients, where the doctors are an employed model, it changes. Okay, that shouldn't make a difference, right? Oh, it does. Coordinated care, but sometimes it's just educational. Let's give everybody the benefit of the doubt. So that's the other point of this kind of referral service. Let's get another opinion, just like anything else. How come you can't send to another doctor to get a second opinion? And so get that second opinion, give everybody the benefit of the doubt, and sometimes that doctor is going to be right. Okay? Sometimes that doctor is going to be right. And when every time they're right, they're going to remind you of it till the end of days. So I try not to have an agenda. I'll try to be very neutral. It's all about the patient and their family and what's more important to them. It's really hard to argue with somebody who's well informed. But there are circumstances. Well, first of all, there's a lot of patients who I see referred to hospice who should not be in hospice, period. And I actually say, you know what, you don't qualify for hospice. As Medicare lays it out, you do not qualify for the hospice benefit, period. And so the other doctor was right. They don't meet the criteria. Medicare's pretty strict, and they're getting stricter and stricter. And they've introduced this lovely system of bounty hunters to go and audit hospices to say, if this patient lived longer than 6 months, I'm going to go backwards and find out if they really needed it. And I'm just going to take all that money back for all the care that you already gave. So hospices owe it to their patients and to their own business livelihood of figuring out what's the rules. That patient is qualified for palliative care. Palliative care is not such a good benefit as the hospice benefit. The hospice benefit is tremendous. I mean, it covers all your medicines, and there's no copays, and the nurses come to your house, and there's no time limit, and it covers all the, it's great. I mean, if everybody can have hospice, it's great. And actually, there's an insurance company that does cover this, where it's a benefit that a patient can have hospice care for the last maybe year of life, and they can still get chemotherapy, and they can still get transplants. Why not? How come they have to fight with each other? That's just Medicare trying to save money. That's the only reason why they made those rules. And actually, since hospice utilization has gone up and up, Medicare is starting cracking down on hospices, trying to drive the utilization down, which is bizarre. But that's the government for you.
Well, it's also financially stupid because it costs less to provide hospice.
In theory, but not in reality. And it's very disease specific. So they've proven that for cancer, but for other diseases, it's actually more expensive to provide hospice than traditional care. For dementia, it's more expensive for Medicare for a person to be in hospice than it is for traditional care. Why? Think about all the things they're doing. What else? They're actually providing a whole lot of care, and it's more expensive than just traditional care, but it works, and it gives the patient benefit. So yeah, it's more expensive, but it's better care. So why not spend money on things that work? We spend a bunch of money on things that absolutely do not work, that are horribly silly and cause a whole lot of misery. And we spend a whole lot of money on it. But suddenly, when it costs a little bit more money for end of life, it's not worth it. That would be my argument. Take the money factor out of it, because if you do that, then we got to rethink everything. Let's say, does it work for this patient? Will they benefit from it? That's a much better test than how much it costs. So try to take the money out of it. The money will follow. If you just do the right thing, what they've proven over and over again, the best quality healthcare systems with the best possible outcome are the cheapest. Across the entire United States, the systems of care that spend the least amount of money provide the best possible outcomes. It's counterintuitive to the American way of thinking, but it's the reality. So the less money I spend, the better the outcomes. And that kind of study kind of reflected it, but it's just what we're noticing again and again and again in all spectrums of health. It's very rare that the more expensive thing is the better thing. Very rare. Yes? Parkinson's qualifies for the hospice benefit. It's always appropriate to do palliative care, and Parkinson's that's starting to affect quality of life. There's a lot of good treatments out there. Some of them are very aggressive or invasive treatments like brain stimulators. The medications have side effects associated with them. But in general, they're all palliative. They're trying to improve quality of life. They can't cure the disease. They're working on stuff that might, like stem cell transplants and really cutting edge stuff. And there's certainly a role for that. But there's also a major role for palliative care. And what it would be is figuring out when would be the right time for hospice, talking about certain interventions like feeding tubes that a person may or may not want. But for Parkinson's, it's very different than dementia. For Parkinson's, feeding tubes might help. Might help. Because if you can take your medicines and you can have function, but on bad days where you can't take the medicines, you might rapidly decline. And if there was only a way to keep giving those medicines even on the bad days, and on the good days still take them by mouth, it might prevent decline. So I can talk about that. It's not a perfect thing for sure, and there's quality of life issues, there's dignity issues, there's body image issues that are important. We discount them too much, but they are important. And just because you have a feeding tube doesn't mean we always have that you can't eat by mouth. There's another thing that I see a lot of people talk about, where if you have a feeding tube, you're not allowed to eat. False. If you have a feeding tube, you can always eat. You just have to talk about the consequences. But there's very rarely that I see a patient that you're not allowed to feed. So if I told you that, it might change a lot of decision making. You know, if some patients say, well, I don't want a feeding tube because you're never going to feed me. And I enjoy food and it gives me pleasure. How can I not have the taste of food? I mean, a lot of times we live for food almost, right? That's inconceivable. I don't want it. Well, what if I give you the tube and we just supplement your calories and make sure you don't get dehydrated and give you another way to get your medicines? Because eating is taking 2 hours a day, every meal. It's taking 2 hours to eat because there are the issues. But who says you can't enjoy the taste of food? What if you can have both? Well, that changes. Nobody ever told me I had that option. So a lot of times I'm the first one to tell somebody that, and it might change them to say, well, then I'll accept the tube. But this is how we're going to use it. See, so every patient's different. But for Parkinson's, the hospice benefit kicks in when there's been a complication, like an aspiration pneumonia or a pneumonia, that you get hospitalized. There might be ulcerations. The quality of life has changed. The functional status has changed to the point where you're always in bed or always in a chair. You need help 24 hours a day with all the activities of daily life, eating, bathing, toileting. And there's been a complication. And the person says, if I start dying, I don't want to change it. That qualifies them for hospice. Again, we wait oftentimes too late until there's major, major problems. And the person's been in the hospital for a month. And now we're suddenly talking about it, when we could have avoided a lot of that period of time that a person may not have wanted to go through. Yes. Medicare covers palliative care in that you pay for it like they would pay a doctor visit. So if a person sees me, it's however they would see any other doctor, like a cardiologist. But palliative care outside of the hospital is not a formalized program that has a Medicare benefit, unfortunately. That's why certain insurance companies use hospice companies to provide palliative care, and they'll pay for it like a person was in hospice. So what I try to do is I'm trying to work with some home health companies to build up their palliative care skills. So for a patient who doesn't want hospice or doesn't qualify for hospice because of Medicare's rules, they can get some support at home from nurses and maybe physical therapy and interdisciplinary care, and guided by a physician to kind of put together a palliative care program that Medicare does pay for inside of whatever rules they have regarding home health benefit, which is very different than the hospice benefit. But some companies, home health companies, are recognizing this and seeing it as a demand that patients have and are developing these skills to provide it within the framework of the home health benefit. But otherwise, really, what I have to offer right now is more of a goals of care, consultative, symptom management, pain medicines, just like you would go see a heart doctor, which is still better than not having it at all. Yes?
And if this type of service is something we're trying to bring into our facilities, I work with hospice companies all the time.
Yes.
Trying to get at least some type of active understanding of where the quality of life meets, treating symptoms and
Right.
whatnot. What type of treatment plan is best suited.
Right.
And we have a lot of patients that are under what we call comfort care, which is just the facility. I work with a nursing home
Mm-hmm.
down in Potomac, and I work with hospice companies all the time, going, please try to get this person on hospice.
Right.
Talk to the family, try to get them to understand what your role is and how you can greatly improve the quality of life, especially when some dementia issues are coming up, and of course treatment plans that are not really suitable.
Mm-hmm.
To get that specialty service that you provide, you just mentioned you could be a consultant.
Right.
do you have a I've got, like I said, 20, 30 people that I'd love to have on consult
Right.
For that type of service that you're talking about.
Right.
It's perfect to kind of complement what we already know they need,
Right.
but they're unwilling to do the hospice route.
Exactly.
How would we go about doing that?
So it brings up a couple of points. One is, does everybody realize that Medicare technically does not have a nursing home benefit? Doesn't. Medicaid does, but Medicare does not. What Medicare has is a skilled nursing benefit that covers up to so many days of rehabilitation or therapies that required skilled nursing care. This is a national issue where, because if you had to pay cash to be in a facility to provide you care and Medicare won't cover it, that's a big barrier for a lot of patients. And so oftentimes nursing homes are in the role of taking care of hospice patients under the skilled nursing benefit. This is nationally, because Medicare is very unbending and they're not trying to evolve very well. And so they're the system is driving these outcomes. So a lot of patients who are dying end up in nursing home under the Medicare benefit, which would mean that they can't also have hospice at the same time, because Medicare says we won't pay for both. You can have this or you can have that. It's not the hospice that's making people make choices, it's Medicare. Medicare is the one putting those choices. Part of the Affordable Care Act was a little paragraph that they snuck in, really, to deal with children who need hospice. That happens, and I'm one of the few doctors who takes care of pediatric hospice, because this happens at any point in life, from birth until a person is 110. This happens, death happens. I know we don't like to think about it, but it happens. But for children, it was pretty bad for Medicaid to have to make a parent choose between comfort and cure. And most parents never made that choice, and there was a whole lot of suffering. So part of the Affordable Care Act mandated that Medicaid pay for cure and hospice simultaneously for children, which is defined as anybody 20 years old and younger on Medicaid. So they don't have to make that choice, but everybody else does. And part of that reflects what happens in nursing facilities. So a lot of nursing facilities have seen, just like hospitals, hey, this is an issue. Can we figure out a way around this? Either we fund our own program to do palliative care like hospitals do. Okay, so hospitals, if you wonder how come I can spend an hour with a patient and other doctors can't, it's because I'm employed by the hospital and I don't have to worry about collections or whether my patients can pay or whether Medicare pays me for that time. It doesn't matter. The hospital says, we need this, this is important, people need it, we're just gonna fund it. And that's how it works. It's not entirely generous, because if you understand how hospitals get paid, it makes perfect sense. And that's why most hospitals have this now. So how do you bring it outside the hospital, though, to facilities or to the community, is the barrier, because really, like I said, nobody pays for it more than any other doctor. For every patient who's diagnosed with cancer, over 120 patients who's diagnosed with cancer, there's one oncologist. For every 1,250 patients who needs palliative care, there's one of me. In this town, we have about 5 oncologists, and we have one of me. In the whole Cameron County, we have one of me. And we have how many patients? In all of Hidalgo and Cameron County, and Willacy and Starr, one of me. So that's a big deal. There's other doctors who are trying to do what I'm doing, who are getting trained to do it, who are doing the certification, and I love seeing that. We might have a whole lot of more doctors soon who are trained and certified to do this, but I'm the only one who I'm aware of who's doing this full time. Just palliative care and hospice. There's a lot of other doctors who are great at hospice, who are doing hospice, but I'm the only one doing it full time. So when we talk about going to facilities and going outside the hospital and opening this clinic and doing all these things, it's one person, one doctor. I have a whole team, and my team's over there. Annette and Henrietta. I'm not going. And so with their help, I can sometimes get out of the hospital, and I'm trying to go to the hospital in Brownsville, and I have a nurse in Brownsville also, and trying to use that team approach. So I figure, if there's a way we can work as a team together to bring this important service to the community, yeah, absolutely. It's the funding on it is very challenging. And maybe Medicare is going to change. Like I said, if they change the way people are paid for things, instead of just paying for doing more, if you're paid for doing what works, maybe it'll change. But right now, hospitals have to do this themselves because nobody else is really doing it. If that answers the question in a roundabout way.
So is
Yeah.
there a billable?
It's just like any other visit. So I get paid for spending an hour what the other doctors get paid the same for 5 minutes. And that kind of answers your whole question about why this happens. That's why we're trying to do the clinic, because what I've seen too much is it's a crisis. And if I had only talked to the patient before we did all these things to them, they would have said a lot of the times in their own words, their own decisions, I don't want that. So we did a whole lot of stuff to somebody who didn't want it if they only knew. That's a shame. So if we have a way to reduce that from happening by giving the patients choice. And the other thing that I want to make clear, this is not a death panel. That whole politicizing of this, they try to put reimbursement for palliative care into that Affordable Care Act, and it got labeled as a death panel because they were trying to figure out a way to pay for my services specially, and they said that's a death panel that I'm going to decide what a patient gets, and so they're not going to pay for it. So they took it out of the bill. And that's the reason why there is no funding for palliative care, because that's what it got labeled as. But in reality, if you had just said, well, it's a doctor who's going to spend time talking about these things, and is that worth doing? Probably it would have been. But the politics on it are really harsh. So that's that story. So until we fix the system about how, why do we expect anything different if these are the rules, we're going to keep getting more of the same. Yes?
Castillo, what advice can you give us as a patient who has had the same doctor 5, 10, 15 years to get them to discuss issues like end of life and diagnosis and symptom control, and perhaps a referral to palliative care?
Yeah.
What is the best leading question when they're either too busy, which is what we hear in the hospital?
Right.
The doctor never told me, he was too busy, he did 5 minutes. And what is the best way that patients can get their physicians to talk about their needs?
Again, if you're talking about doctors who just want to do the right thing for the patient, just offering it and telling them about it, that it's available, they'll use it. When I first talked about palliative care, most doctors who heard about it say, we already do that, we don't need it, what do I need you for? And then we did about a year of education at this hospital every month, giving a lecture, and at the end of that, everybody said, wow, I didn't realize that's what we're talking about here. Yeah, I think I do have a lot of patients who would benefit from this. So just build it and they will come kind of thing. Still, you won't get everybody, but as the culture starts changing and it becomes expected and the standard to do it this way, the peer pressure builds and everybody starts coming along. New York has a long experience in this, and they used to be just tremendously high burden end-of-life treatment, and as a state, they've dramatically changed because it's not normal anymore to do the things they used to do. It's normal now to do palliative care, and if you don't have it, it's pretty weird. Right now, we're in this transition period where our program, compared to other hospitals and as part of our health system, we're a part of Vanguard Health System, we're the busiest program in the entire country. The busiest in between Phoenix, Chicago, Detroit, San Antonio. San Antonio doesn't even have a program, actually. Boston, we're the busiest. So we went from a place where 5 years hospice was hardly used. In McAllen, Medicare spent on average $45 per Medicare beneficiary in the last 2 years of life on hospice. Dallas spends $400. Okay? There's a dramatic underutilization here, but even in just a few years, 2 years since we started the program, it's become much more popular. So I think it's build it and they will come, but most doctors listen to their patients, and if patients really don't feel their doctor's listening to them and they want something different, you're always empowered to change. I mean, this whole idea that, oh my goodness, you're going to offend somebody, it's your life. Honestly, it's your life. You can't deal with that. But most doctors, trust me about this, just want to do the right thing. And if I can give that option to them to help, I'm offering help and support, most doctors will choose it. It's just brand new, and anything new, everybody's kind of cautious. Yes?
I do want to kind of tag along with that. I don't normally go out and see doctors and go to the practices or the administrators in the building. So I have gone on several occasions to large physician groups here locally, and we kind of discuss like our direct I mean, they go, well, how do you have the conversation? I go, well, I think that's something really a physician would start with,
Yeah.
and we can follow up with.
Right.
But, I mean, they kind of had the same question as, what do we do with these folks that we know are declining in
Right.
function, are not doing well at home, they're falling and having, you know, a lot of ADL needs. I know that the pump is prime. They just
Oh,
kind
yeah.
of need an outlet to kind of say, you know
There's-
what?
there's
this might
demand.
be an opportunity for what you're doing.
And don't forget, again, in my medical school training, I was never taught how to talk to a patient about end of life issues. Most physicians never have been. And in the residency program, nope. It's just something that if you realize is important, you can acquire the skills. And like any skill, some people might be better at it than others, especially if you like it. If you like doing something, you find value in it, you're going to get better at it. So this is something I see tremendous value in doing. So I've tried to build the skills in doing it. Not all doctors have that. That's fine. It's just, well, if you don't have it, again, this needs to happen. So giving an option to refer is great. And it's not about passing the buck. This is hard. This is not easy for a doctor to do either. It's necessary. But if I can give help, that's the point. That's what matters. I guess everybody really likes hearing me talk. An hour and a half.
Good. Even, back to that lady's question, will your physicians still be a part of the team?
Absolutely. And again, so how do I deal with the doctor who says, well, it's my way or the highway? Patients can vote with their feet, quite honestly. Now, Medicare throws some loopholes in that. Because to get on hospice, you need a doctor's order. You can't just choose to be on hospice. Medicare doesn't let the patient decide. Like I said, it took 2 doctors to certify a patient. So this is a scenario where I've gotten called to go to people's homes and where the doctor says, I'm not going to put you in hospice, and the patient and their family want it. So this is where I can come in and give you an alternative. I might not make friends, but most of the time, again, it's what needs to happen. And if I'm doing the right thing, I'm doing the right thing. But that's rare. I know you can usually deal with it. It's rare that I run across those kind of situations. Thank goodness.
Thank you,
Yeah.
Dr. Castillo.
Thank you.